today we are here just like a table talk. It's not as our traditional discussion of topic, you understood, but this is very important and technically very reasonable to know from those who already passed our OSCE and what they are thinking. Um, Everybody might have some mistakes, some errors, but somebody could pass, somebody couldn't. This is the fact. So today we like to invite to our topic already the simple thing, just to listen from them. If you want to interact with them, and in between, if we have our some saying we like to add here, that's all. And if you have some experience to share from anybody else also, you have heard, maybe your friends and others, you can join with us just to make an summarized plan for us. The every plan will be individualized. So it will be our pleasure to introduce our colleagues, those who were with us before. And we invited all of them, but somebody might not join for other purpose. And today I find here those I already have connected. Dr. Arvind possibly here. Dr. Arvind. Dr. Arvind, can you hear me?
Good evening. I'm here,
Good
sir.
evening. Thank you, Dr. Arvind. Hopefully you will remain with us few minutes
Yes, sir. Yes, sir.
in
Definitely.
in your very busy schedule, and we are very grateful to you. And we will be very happy to have some other colleagues also. Dr. Shazia, Dr. Sarah, and others as well. If they are having their time, they could join. And possibly all other colleagues are waiting to listen from you all. So this is our actually privilege to congratulate our colleagues and to listen from them. I think Dr. Arvind also happy to share his views with us. And definitely Dr. Arvind is thinking that how can he help other colleagues, friends also to overcome the barriers. And we have some expressions or what I say, the comments in the group also, even individually in our inbox that some doctor couldn't pass. They are thinking that they are quite enough prepared. Yes, it may happen. Even you are prepared. Rather to say, so-called accident may happen. But these accidents, the chance of accidents are very less, though it may happen. In general, if you are not equipped with the skills rather, that I like to highlight again at the later part of the discussion after listening. Dr. Sarah, please, Dr. Sarah, possibly you are here. Dr. Sarah, can you respond, please?
Salam alaikum, Dr. Osman. How are you?
Welcome, Doctora. Fantastic to see you. Just be with us, and many colleagues are waiting to listen from you today. Okay. It will be a great opportunity for us to listen. Just few days before you were preparing, now today you will be guiding to us and what we can do also. I think it is a very great opportunity. Thank you, Dr. Sarah, to be with us. And I'm searching other colleague and other colleague also, those I didn't have contact till now, but you have passed. You can join with us, doctor, with free and frankly. And you already understood that always we are trying to help each other. Everywhere there is a give and take, no doubt, but actually to build up your career. This is our
Salam
motto.
alaikum, Dr. Osman. Sorry, I got cut from my call.
No problem, doctor. You take your time. Dr. Intisar here also, doctor?
Yes, I am answering from her phone. Yes.
Oh, with her phone. Thank you. Thank you very
Yeah.
much. Oh, no problem. No problem. Be with us, doctor. So we will be waiting for others. Don't feel shy to talk today. So may I request Dr. Arvind, please, to start actually, it is not my session, rather to say, and I am just organizing for all of you, inviting you, giving the technical support. Our speaker will be the colleagues who passed OSCE. They are our speaker today. So may I request Dr. Arvind, please, are you free to talk now? And just you can remember your experience in the exam. Dr. Arvind, please.
Thank you so much, sir, for giving me this opportunity. And I welcome all the listeners here. So I just cleared my OSCE exam in Chennai. My exam was on second day on 22nd,
Yeah.
and this was my second attempt. Last year I appeared in Colombo also, and I failed quite well actually. So and my preparation was also far from ideal this time also, and I repeated the same mistake which I did last time, that I contacted sir at the very last moment. So, but in the meanwhile, I was listening to lectures all the time. But I believe even though I cleared, I didn't practice well. And in last few days, I practiced with sir, and sir was also of the opinion that mine is a borderline case, that he gave me very good feedback. So one thing I did, the only thing I think I did better than last time, that on every station, I was like with every passing station, I was trying to, whatever happened in that station, I was not bothered about it. And DOAMS format, I was just revising on every station. I was just going through format. I just didn't want to miss anything. It may sound a bit mechanical, but I just revised the format, and I focused also on non-pharmacological things. I mean, like non-pharmacological advices and lifestyle advices. I did last year. Last time I was more preoccupied with diagnosis and finding the diagnosis quickly, and how to tell the right medicines. But I think that's not what Sir also wants us to, and we should look holistically. Like, three biopsychosocial that Sir keeps repeating is very important. So these are the little things I did okay, I guess. And there was one station where I think I in fact, after coming back from exam, I told Sir that I didn't do well in that station. I think I got it totally wrong.
Yeah, I can remember. I can remember.
Yes. So I and but somehow I passed. I'm really grateful to the God, and but my everything I've been guided by sir. I have listening to these lectures, and I haven't practiced with also anyone, which is not the right approach. I suggest everyone to please practice, and practice as much as you can.
Yeah,
They are.
thank you, Doctor,
Yeah.
for your introduction. I think
Thank you,
you
sir.
will remain with us. In the meantime,
Yeah.
if I have, I will ask you also something. And but the preference is to the audience today. If any audience wants
Sure,
to
sir.
ask you, ask to me as well, even other colleague also here. But Dr. Arvind is ready to respond. Please, anyone, open the mic and you can take part in the discussion. Any colleague to know something about the exam? This technical thing is very important. What Dr. Arvind said, that the checklist, rather, he said, yes, it actually sound as mechanical. Our DOAMS checklist, rather to say, always we were telling these just keep this structure in your mind, but it should be customized. It should be fit with your patient. This is very important. But what you like to knock, if you don't know beforehand, you cannot specify your target. For this reason, this chart is important. And what Dr. Arvind said, I can remember in his very short possible time so far, right, Dr. Arvind? He was having very less time before exam, maybe 1 month or little more than 1 month.
Yes, sir.
Is
Yes,
it?
sir. 3-4 weeks. Yeah.
Yeah, you are shifting from the some place to other part of your country and having no time. But I believe that Dr. Arvind was actually preparing for a few months before, more or less, but not in very organized fashion. So far, I understood. As a mentor, I have to understand my colleague, my what I say followers. So for this reason, the tricks and tips given to him is just a strategy. For this reason, the strategy was successful for him. That is the thing. Otherwise, knowledge, whatever you are having, that is enough. What you need to prove it by practice, practice, and practice, what Dr. Arvind said. Please, still any colleague to ask anything now until? Please open now. No need to listen only, doctor. If you have time, you can take part in the discussion. Yes,
So,
Dr. Nazia, please.
yes, I have a question
Yeah.
that for the practice part, he ideally how many cases he was practicing every day with partners?
Before Dr. Arvind answering, I like to say that it will be individualized. Depends upon your time and other thing, but Dr. Arvind can respond now. Dr. Arvind, I think you understood the question.
Yes, ma'am, I'll say again, mine is not the ideal way to follow. I practiced very less, and I could feel that I practiced very less. So don't think I should be the reference point for it. So,
One more question, if you don't mind.
yes, yeah.
When I am practicing with my friend, we are putting the timer of 10 minutes. We are always falling at 13 or 15 minutes. So this, you were facing this problem in exam, that there is so much to cover and how to finish it in 10 minutes. Any tips for that?
There's a that is another thing I forgot to mention, that this focused examination, sir, has videos and everything. So we should, rather than whole general physical examination, the focused examination saves a lot of time. And if we are thorough with the checklist, and it comes naturally to us. The examination should be very focused. That's very important because it takes a lot of time.
Yeah.
Can I add something, Doctor?
Yes,
Yes. What actually Dr. Nazi asking, I think that I will say about the time management, technique of time management. This is the fact. And I think in the technical point of view, this is the most important part of your orchestration. Why you are having 13 minutes, 14 minutes, for example. Actually, you don't know how to manage your time. And I think Dr. Arvind can remember, and for other colleagues also, what we do at the end of our OSCE case practice, usually as a surrogate, I was asking a question. I think Dr. Arvind also can remember. And this question could be answered in single word. But we are having the habit to say in a longer way. And time is over. I think Dr. Arvind, you can remember. For example, Doctor, how long can I survive? For example, in a Breaking Bad News or somewhere, what will be my longevity like this? So, what
yes,
will be the answer? Answer will be that only God knows. For example, or I am not certain to say. This is enough. 2-3 seconds. But you are telling, as you are having this disease and this very advanced disease, and I'm very sorry to say that no treatments are there and there. How can I say you it may be 5 months, 6 months? So what you are telling everything is okay. We all are true, but you are taking time. Okay. But
Agree.
I just to tell you in another way also, in our day-to-day simple conversations in our life, if somebody asks you, what is your name? We learned in our primary school by saying that my name is X, for example. But if somebody asks me, what is your name? I can say X. Is that enough, Dr. Nazia?
Yes, it's enough.
That's all. Anywhere you can fit this strategy to save your time. And the last 2 minutes, we tell it very golden time, last 2 minutes, to concise everything. And this is the time you can manage yourself. If this 2 minutes is the best, it will be best for your performance. You can cover many things what you didn't do before within the 8 minutes. And always we tell, and somebody already know about us, that to ask the surrogate, do you like to add anything more? Do you like to ask anything more? It will give you the best benefit at the end of the consultation. These few of the example, Dr. Nazia, for you, how to manage your time. Dr. Arvind, to say anything more now?
yes, sir. This has helped me a lot during exam. That do you like to add anything or do you like to ask anything? It's very, very important.
I think you have
Because
done it in the OSCE exam.
yes, sir. Because I did it for sir, and because what happens that many time it helps you in getting the agenda of the patient, or
Yeah.
if they is trying to give over some clue.
Clue,
So
yes.
yeah, so we can keep it in mind, and we can either answer it. Question. Go with it at the moment, or we can tell patient that that you mentioned about this. Can we come back to it later, or
Yeah,
whatever?
yeah.
Yeah.
Yes.
So
So
this really helps because
very
if it
nice to
goes
say.
it
Yeah.
goes in the last 2 minutes, sir, then again we feel that the structure has gone missing if we don't do it on timely, sir. It really helps.
Yeah. Dr. Nazia, I think you understood what we
Yes.
should describe. Thank you, Dr. Nazia. Any further question, Dr. Nazia?
No, I think he's right. It's just more practice and keeping the patient to the point.
That's
And When I appear for my CSA exam in Chicago, I try to do the same strategy and it helped me.
That's all. That's all. But again, I like to say we have to create our own words to say in very short, not short, a few words to express our views, informations. That is very important. Thanking you. We can come back to you again if you have anything to ask further. Any other colleague, please? Can you open the mic? Yes. May I know your name, doctor, please?
Sir, I am Dr. Aslam from
Aslam,
Rahim Yar
welcome,
Khan.
doctor,
Yes,
please.
Pakistan, Rahim Yar Khan. I am
Oh,
from
welcome,
Dixon Village.
doctor, please.
Sir, first of all, congratulations to Dr. Arvind. And I will like to ask a question that how many stations were there in which you was not clear the diagnosis about the diagnosis and you proceeded well?
Yes, Dr. Arvind.
Thank you so much, Dr. Aslam. So, we out of 14 stations, diagnosis, there's one station where I was pretty sure that my diagnosis is wrong, and other stations, diagnosis was not very hard to miss. But it took. I mean, sometimes I got it. I mean, in quite early in the session that I reached on the diagnosis, and some in later. But this time I was not worried about diagnosis actually. I was more following the structure, and rather than what happens if we reach on diagnosis, it makes us make if you are extra confident, you'll miss some warning signs, which has happened with me last time. So I just wanted to be pretty sure of my diagnosis, and I mean, like, diagnosis was not the focal point for me. I was just wanted not to miss any red flags and
Yes.
anything follow up.
Of
Yes.
course, of course. I
And
like.
safety
I am
netting,
very agreed with Dr. Arvind
safety netting.
also.
Huh.
The points and the checklist, if you everybody could see our checklist also. And Dr. Aslam asked about the diagnosis. I think this is in my sense. Dr. Arvind, sorry, I just
Yes, sir,
invaded
sure,
you
sir.
in your talk. I was waiting because all the time I was telling in my session that the diagnosis is not the main focus in the consultation. I will show you again what the examiner mark sheet also just at the end of today's discussion. The red flags and others to prove ourselves we are safe doctor to the patient. So it is not the diagnosis. Even without knowing the diagnosis, you can identify the red flags. We can prove that I am myself as a safe doctor for my patient. This is more important than the diagnosis. But what Dr. Arvind said, it is true that most of the stations to reach the diagnosis is very easy. As we actually passed our graduation many years before, we are seeing our patients, we are trying to get some training from somehow. So it is not very, very crucial to say the diagnosis. And unfortunately, if you miss the diagnosis, yes, there might be some hazard that the further management plan other will be is disturbed. Even then, you could rescue yourself. Again, it needs some technique. So it is not the time to discuss about that, but what Dr. Arvind said, I am also with the same opinion. Dr. Aslam, having any further, please?
No, sir. Thanks, sir. Your guidance is very nice.
So don't think that diagnosis is a matter of knowledge. Okay, you can prove it, but other than the holistic approach, biopsychosocial diagnosis, 3-dimensional diagnosis, and to make a problem list in the management part. Even you couldn't reach the diagnosis. This is also problem. Understand?
Nice, sir. Nice guidance.
You couldn't get the diagnosis. You just share with the patient. I'm sorry that Mr. John, I couldn't reach exact what is the disease of you're having. I need some time to tell you later. You just rescue yourself in this way, but don't tell some wrong thing to the patient. This is ideal. So anyway, Dr. Arvind, thank you to share your any other colleague, please. Can you open to ask? Those who want to ask, please, you can keep your hand raising in the system so that we can invite you one by one. Dr. Sarah here. Yeah, Dr. Sarah, to add something. Yeah, welcome, Dr. Sarah, and it is our privilege to present Dr. Sarah here. She just recently passed OSCE. And please, any additional response from you, doctor?
Yeah, when I started practicing, I didn't have much confidence, and I believe you made me more focused even in my real life. how to be focused in consultation with the patient and to take the points systemically. And the patient sometimes will divert you and how to bring him back.
So
Like if the
patient
patient
diverted means you mean that they just to make you distracted?
yes, they
Sometime.
will divert you. Sometimes they will be difficult patients.
So this is
Sometimes
the
I
this is a
remember,
technical thing you mean technical thing, doctor?
yeah, yes, you made me understand how to be professional because whatever it is,
Yes,
I'm
yes.
his doctor and I need to manage the time for him and for me to be productive. So at the same time, to be very precise with my work because I remember I talk too much to get to one point. Yeah. So for example, in the management, I will tell him I'm going to give you this medicine and it will do this, and maybe by that time the patient has already slept. You made me understand. Give him chunks of information and make sure he processed it and say, "Are you okay with it? Can we proceed?" And give him the next block. The next
Yes,
block.
yes. Thank you, Dr. Sarah. That
Yeah.
actually our teaching also, I like to add here level of understanding or the understanding by the patient or the surrogate. We discuss about the 3E model, 3E. First explore, then
Yes,
explain, then next one, Dr. Arvind, explore again, right?
sir.
Explore, explain, then explore. So last explore actually is very cumbersome. If you allow your patient to tell back, so it will kill the time. So technically, what you need to learn is just to ask, is it okay? That means if surrogate tell that okay, means the third exploration is done. This is the technique all the time. Actually, years together we are practicing it. It is also again time-saving strategy. Dr. Sarah, please, any other to add something? And as Dr. Sarah said, that destruction could be done by surrogate. It might be a new addition in a technique of the OSCE. Actually, it was not happening before. The destruction sometime, why it is there? Because in our day-to-day lives, patients are not trained up person. Patient can tell his or her own informations, but is not relevant for the management. So how professionally we can stop them? I can remember in our consultation skill discussion, there is one point, it is called the active listening. One skill is active listening among the 23 communication skill principles or rules. In the active listening, you will tell, okay, fine. Can you tell me more? Fantastic. But if patient is telling something different, you have to stop. How to stop? This is also a skill. Not the, please stop. Let listen to me. Uh, Not this is the way. And I think Dr. Sarah mentioned it. It should be in a professional way also. Dr. Sarah, any further addition, please?
I feel like you made me to think very systematically, not to rush anything, any step. Go through the step properly and then move on to the next step.
Yes.
And like bullet points in our head, like a skeleton, whatever the case, that skeleton is there. Like not to forget about ICEs, not to forget about key questions. It made a big difference, I think, in the exam. Vaccination history,
Yeah.
allergies, yeah. So keeping that skeleton, I felt confident going into the cases. And in some cases, I was not able to reach the diagnosis, but I felt all the remaining part of the case went well. Perhaps the diagnosis I hesitated, but at least 75% of the case went okay. So, so it's okay not to reach the diagnosis till the very last moment. Then in those 2 minutes left, Dr. Asman explained to me how to make use of that time. Like if I have a very short time, there's no point to waste time on side effects of medication. Just quickly give one side effect, move on to the next one. Safety netting. Cover all the dots. Don't waste time on one part. Yeah.
Yes, nice, Dr. Sarah. I think all of you who are listening, you understood. Still, you have any query, doctor, please? Any colleague? You can open up, please.
Sir, I want to add one more thing.
Yeah, Dr. Arvind, please.
Like Dr. Usman asked me that how quickly I was able to, sorry, Dr. Aslam asked me how quickly regarding diagnosis. So this one patient I got of pneumonia, sir, more than 68, I think his age, and I was so tense that I was not even able to calculate his curve score for admission. So I looked it's 2, 3 and all that, and time was gone. But I told him that I think you needs to be under observation.
Yeah.
And the main thing was that his son was away from him, and there's no one to take care of him.
Yeah.
And so in the considering this local scenario, there was no help. I asked him repeatedly, "Do you have anyone to help you out? Do you have to check one?" I advised him admission. He was not, even though I was not very sure about curve admission, but I felt that, and he asked me repeatedly, "Do you want me to get admitted or not?" I said, "I think you should get admitted, and we'll follow you up." And then,
Very interesting area Dr. Arvind said now that in the family medicine, I can remember when we practiced a case of the renal stone without any illness, the summary is that the renal stone patient to be considered for admission, only that patient is alone at home, nobody is there. Patient might get again the pain immediately, maybe within today, tomorrow, we don't know, but he will be or she will be helpless. So what you said, Dr. Arvind, that nobody is there to take care of the patient, about ignoring the carb 65 also, for
yes,
this purpose, if you say that, it's better to be under observation. That is the safety part that
yes,
your advice is. So how nicely you have overcome it. Very right, very right.
yes, sir. And there was another case of
Please.
ectopic pregnancy.
Please.
So the diagnosis was pretty simple. But I think the main part of the consultation was that the concerned patient was in relationship with someone premarital, and her parents were not aware of it, and she was very much tensed about it. So the whole consultation was that we will take care of it. You need to get admitted, huh? And your safety comes first, and your life matters more than anything else right now. And we will. I told her that we have counselors and. Like to help your family understand and everything how so that was the main part actually, sir, I think, for the
I think here
consultation.
another issue could be there also. It is called the ethical point of view,
Yes,
is the
ethical.
confidentiality.
Yes. Yeah.
So we categorize our cases. I will show you also, if any new colleague, you will see that we categorize around 7 to 10 category of the cases. And that Dr. Arvind actually practiced, and you can remember another
Yes,
colleague
sir.
also, that we actually given a 10 cases mock practice at that time, right?
Yes, sir. Yes, sir. That
So
helped a lot actually, sir.
no,
And
that is the
there's
thing. Yes, please,
yes, sir.
Dr. Arvind. Carry on, please.
So there was another case of glandular fever.
Yeah.
So in that case, I was not able to reach diagnosis. Actually, in fact, after like when they say that 2 minutes left, only last 45, 50 seconds, I could reach diagnosis. And and it was also because I didn't pay attention to my surrounding, that there was a tongue depressor and everything, and I was so much tensed because of that. But in last 40, 45 seconds I got, and I've taken a detailed history that says that basketball player. So I told her not to play contact sports and everything.
Contact sport.
Safety. Yes, sir. So I think that also helped me there.
That's good. Now, any other colleague to open up? Dr. Raid, please.
Yes. Hi, Doctor. I'm Dr. Fariha.
Fariha,
yes, Dr.
welcome, Doctor, please.
Yes. Yeah, I have two questions. One, as Dr. Arvind said, like he did not reach the diagnosis, but he just go with the flow. But my point is, when he did not reach the diagnosis, what he said in his investigation, that which investigations he will do, he just keep the DDs in his mind and he asked for all the investigation, or what he did? What was his approach?
Dr. Arvind, please.
Yeah, so ma'am, like the way Osman sir teaches, we don't say investigation. It's like a jargon not to use, sir has taught. So
it's a test. We have to utter the word test, not investigation. Nice to hear.
Yeah.
Please.
So actually, I couldn't explore all differential. I was more, I was regarding this particular case, I was typhoid and some other. I'm thinking of many diagnoses actually, but then when I looked at the surrounding and everything, it suddenly like I don't know. It's hard to explain the process, but I got this in this particular case. I got diagnosis very late, and I was trying to. Since I was not getting the diagnosis, I was just trying to rule out the red flags system wise.
Can I
And
add something, Dr. Arvind, here? Just
yes,
to
sir.
add
Yes.
with the doctor, the diagnosis, in how many levels we label a diagnosis.
Yes, sir.
Actually,
Biopsychosocial. So,
these are three
uh,
dimensions of diagnosis. For example, one is the biologic, psychological, and the social. But even in the biologic diagnosis, how we make it of different levels, different steps of the stair. Just follow me, I can add. For example, if a patient having lobar pneumonia, so after examination, chest examination, after taking the history, definitely, you got the bronchial breath sound, dullness in the right side of the chest. What we are diagnosing? We are diagnosing is a case of right-sided upper lobe or whatever, say upper zone consolidation, right? This is one of the layer of the diagnosis, first layer. But the next layer should be, what could be the etiology? Is that it? Understand my point? Etiology means which organism is responsible for that. Even it may not be streptococcal, even it could be tubercular. So this is the second layer of the diagnosis. In this way, if you say that I should be very pinpoint to diagnose the case, it might not be the actually possible to reach there. But primary assumption is important. I can give you another example. A patient presented with the back pain. So final diagnosis could be ankylosing spondylitis or spondyloarthropathy. But very thing you understood that initially as a doctor, we are trying to differentiate this back pain is of inflammatory nature or not. If it is inflammatory nature, even without reaching the diagnosis, I can refer the case. I can send the case to the bone and joint department or bone and joint clinic for further evaluation. That means the rheumatology. They can do something more also. In the part of your practice, or rather to say in the exam hall also, you might be confused to say this is spondyloarthropathy. But you could say that I am thinking it could be like, sounding like an rheumatic disease. Okay, not a mechanical pain. So I like to send you to the bone and joint clinic for further evaluation. It will save you rather. Understand, doctor?
Yes, sir.
Not
Sir,
no
but
need to reach specific diagnosis there.
yeah, sir. But one more question. For example, as you give the first example about this pneumonia and tuberculosis, so in that case, if you are confused in the case, so while doing the test, you can further test. For example, you can go for the testing of tuberculosis to be make sure to differentiate.
Okay, if you think that our differential including streptococcal pneumonia as well as tuberculosis, but unlikely tuberculosis will be a chronic process, few weeks, 3 weeks to 4 weeks. At that time, it is unlikely to be streptococcal pneumonia. But when it will be likely, if it is a partially treated pneumonia initially. So in
Yes.
that situations, you need to include the etiologic test, for example, sputum study, for gram
Yes.
stain, for culture sensitivity, for the acid fast bacillus, for the gene expert test, means the PCR of the tuberculosis. All together, you can advise, you can plan for this.
So, for example, sir, if it is case, in that case, if it is positive, it's tuberculosis. They will provide us the lab result.
Oh, yes, definitely. They are ready to give you. For example, if they design the station, they like to hear from you about the treatment of the tuberculosis, for example. Then definitely they will tell you the findings. But
for
if they
if
don't want to say, don't want to hear the tuberculosis only, they want to hear from you your evaluation capability, they may not tell you the findings. Just it is kept pending. They will tell you the reports pending. It will be given later. This is the strategy technique.
okay,
We had
Dr. Sarah, please. Dr. Sarah, can you check your mic? I think you could improve your sound if possible. If possible. Otherwise, we can hear. Yeah.
we had one patient, I think 21-year male, 10-day history of fever,
Yeah.
and received amoxicillin for 4 days,
Yeah.
with fever ongoing and not improved, dry cough.
Yes.
And otherwise his vitals were okay, but he had high fever, 39, saturation I think 96, respiratory rate okay. So they asked us, what's the management for this patient? Like, what's the plan for this patient? So in this case, it's dry cough. So I didn't say sputum culture. I said it might be atypical pneumonia.
Okay.
No indication for admission because he's vitally stable, but safety netting within 2 days if he doesn't improve treating atypical pneumonia to admit for IV antibiotics. I'm not sure if I was right or wrong, but I was thinking it's dry cough. How can I take sputum?
That is a very technical
So
thing. It is very nice to say. But for further addition, Dr. Sara, though it is approved in MRCGP OSCE exam, a dry cough, we are not advising for the sputum. But when I think as a doctor, for all of you, I'm telling, that sputum study is very important. Then it is said as it is called induced sputum. There is a technical way to collect the sputum. For example, giving the 3% normal saline nebulization, it can produce. So it is very extraordinary attitude to show there. But initially, your avoidance that okay, if not needed, I don't need to do sputum study right now. I can keep my patient under observation. This is the best way by the family physician in the primary assessment process. This is very, very true. So what you like to say means that the specific investigation, diagnostic test, result of the diagnostic test are not always important. Right, Dr. Sara?
it was about the process of what am I planning for my patient and is it safe?
Yes, it is safe. Again, always the word is safety, safety, right? Safety by the doctor, right?
And when I gave him the safety netting, like okay, if you haven't improved within 2 days, the SP gave a look to the examiner, like it's okay, move on. I will move on to the next spot.
Next,
Yeah.
right. Thank you. Sometimes SP also do some confusion, and if time is there, I can tell you the story of Sri Lanka of myself. What happened to me? Any other colleague, please, to tell, Father? Dr. Shazia, I am expecting Dr. Shazia also could be here. Are you there, Dr. Shazia, or any other new colleague, those who passed and you remained with us before? Any colleague to add something? Another colleague having nothing, I think all of you understood what our very nice colleague, brilliant colleague shared with us. Anything else, Doctor? If no more, we can proceed further, and I have to summarize something also for you. And Dr. Arvind and others here. Just it's our pleasure again to introduce this gentle lady before. I think Dr. Sara is from Sudan, right? Dr. Sara?
Yes.
You're
Yes,
from
from
Sudan,
Sudan.
and she's
Yeah.
you're also from Sudan. She was with us before, a few years before. She stood first there, and it is our pleasure to introduce her. Anyway, but at the later part, what is my talk is that the examiner is sitting with such mark sheets, and you see that there is no point that what is the diagnosis of the case. Very interesting. Right, it is copied as it is as Royal College. So there's no way that where is the diagnosis. They have given consultation skill, data gathering skill, examination or counseling skill, then management and investigations. Okay, you could ask that how without diagnosis, how can I manage? Yes, apparently it could be a question. But what you learned from today, from our colleagues also, how they have faced the situations in the exam without pinpointed diagnosis also, you could manage, you could create a management plan. It is very, very possible. And again, you discuss with your friend and think how it is possible. Being non-specific also, you can make a good management plan. So for this reason, management plan and investigation planning, these skills are very important. And very recently, we have updated our basic module about this. Very recently, within few weeks also, most of you possibly have seen that we talked about counseling skill. We talked about the management skill. We talked about, rather not talking, rather to say we discussed about investigation skill. That means planning of investigation. These are very important. So you will be marked according to your skill. So skill, skill, skill. It is most important thing. For this reason, diagnosis, don't actually be worried about that. Again, to say, be a safe doctor. This is most important thing. And just to say you that everything you are doing, but you see now, you have done a lot of works, but if not in a proper way, thing could happen in this way. You could feel helpless like this. I think all of you understood what we mean. And if you are intelligent, you could do this thing also. Right, Dr. Sarah? Another, you understood what we mean? A broken material, how could be useful? Just very simple tricks, okay? It could be useful. And in the scale, just can you see the animation? I don't know, have you seen before or not? Just few seconds. Look, this man, please. Sorry, I think I cannot share the sound. You just follow, few seconds. What actually scale means? I think all of you understood. What is the meaning of scale? Okay. Dr. Nazia, do you like to comment? You open the mic.
No, I am just saying it was very interesting video.
This
Sometimes
is the
common sense is not very common, so it's just common things which will help you pass.
that is the thing, and that is our strategy to discuss, to guide you how to pass. Every exam has its own strategy, unique strategy, and this is the blueprint, or it is called the matrix. It is called matrix in our teaching methodology, and they create the cases accordingly, acute, chronic, and so on. For this reason, our previous colleague know that we actually design in this way, a little customized. In the 7 main headlines, and in the 7 miscellaneous, there are different types: breaking bad news, angry patient, legal and ethical cases. Already you have heard from Dr. Arvind that there was an ethical issue also. Every cases have some touch of ethical issue, could be there. But some station main focus will be ethical issue. It is called the agenda of the station. If you could reach there, what is the agenda? It will be very valuable for you to overcome the station. Okay. And why so many people failed in this? Dr. Shabana, you could raise your voice, doctor. Better not to write. Why many people failed? Actually, you could see. I don't know. Did you attend before? We discussed a topic: common mistakes done by the OSCE candidates according to the Royal College examiner. We discussed in the last maybe 1 month or 2 months, detail in different skill. Already I have shown you in the communication skill, what was the mistake? In the examination part, what was the mistake? In the management part, what was the mistake? There is a list already. I think there's a less time to discuss details. You could actually search this thing. So these you need to develop yourself, not only the diagnosis and others. I told in the last day also maybe that the knowledge you can gather from your books. You already have the knowledge, but it should be put into this category, different category of the patient, because strategy will be very, very different from each category almost. So near about 9 to 10 things are there. So try to improve your skill. This is our suggestion. And doctor, at last, I think this is those who are appearing in the Colombo exam. This is the short plan for you, as many of you asking how to reach the final target of preparation. This is our thing for the candidate or examinee, and to create your basics. Actually today, now any topic we are discussing, this is our basic module. Those who are relatively beginner, you can communicate with us, doctor, that only not that you are reading the thing. Again, listening, very important. Today, for example, many of you listening today, you to understand. So you need to listen the discussion records. You need to share with each other. Even one thing is that you need to be examiner also. And I remember that in this module, we have given one class. It is called virtual OSCE observer. And I can remember in our previous time, colleagues were, those who were learner at that time, they played the role as OSCE observer. And I think it's very comfortable to be observer rather to be candidate. And they have given the marks to the candidate. Okay, you score this thing, this thing, this thing. It is also indirect way of learning. When I feel that I am examiner, then I would think what I expect from the candidate. So when you will be actually real candidate, it will be easier for you to express or to convey this, to share with the surrogate. For this reason, we design in this way detail. So actually, no time too much to say further. You could see the module here. It is open in the group, in the WhatsApp group, doctor. So, and I think we are at the end. If any colleague not in the group, always we are sharing the link, and you can join, doctor. Just you can see, see in the chat box. Sorry, doctor, here where it is. Give me, Dr. Saima, please. You raise the hand. Anything to say?
Sir, I discussed one case with my colleague who could not pass.
Okay, sorry
Uh,
for, yeah.
and I also could not pass for
Okay,
few
sorry.
months.
Anyway, there is a time, and this happened to many of the colleagues. Don't worry, we can talk each other later on. But what you actually add, please want to add?
Yes, sir. It was about a case I wanted to discuss because it was a case like for bronchiectasis. The
Yeah.
patient, like 45-year-old male, he brought the report of X-ray,
Okay.
and X-ray was showing dilatation of bronchioles, like bronchiectasis.
Okay.
And after proceeding with the case, he was a smoker
Right.
since 30 years, but 10 cigarettes per day. And there was no wheezy sounds on examination, nothing so much significant, and no history of atopy or asthma, and no history of TB contact.
Yeah.
And he was having sputum production more and more green colored,
Okay.
and no diurnal variation.
Okay.
So, in the investigation, anyways, because I did the case with her, and then I asked that for basic investigations, chest X-ray was already there. Then I told that there can be this is bronchiectasis, explanation of diagnosis, and then for further workup, I would like to have sputum AFP and sputum culture sensitivity, and also I would like to have a look by the chest physician.
Okay.
But discuss the case with some Dr. Mahmood. He wrote spirometry also because. Although it was a bronchiectasis, there was a confusion for that one. I wanted to ask that spirometry is usually for seeing restrictive or obstructive lung disease, and also for obstructive, definitely to check the variability after bronchodilators. But in this case, when there is a bronchiectasis, mostly there can be, in my understanding, there can be like post tuberculosis, bronchiectasis, or post COVID pneumonia somewhere, and then the patient might have developed this one. What do you say regarding this investigations?
You need to know about the investigation planning of the pulmonary function test, you mean? Spirometry?
I wanted to ask that bronchiectasis, in my understanding, is mostly a result of some past infections.
Yes, usually it is the nature. Previously, even in the childhood, there was a respiratory illness. There's some persisting defect, preferably fibrosis also there. And the later on, the patient develop repeated infection, and finally bronchiectasis develop. And usually it is said that bronchiectasis is the end point of chronic lung disease. Not only the tuberculosis, rather even the asthma or even the COPD also. Until there is development of malignancy, bronchiectasis is the end result of the chronic lung disease. So your understanding was right. Yes, Dr. Saima. So what your confusion or anything there about the case?
Sir, about spirometry, because I didn't ask in my doing that for spirometry, but whether it is needed,
Oh,
because
what
it
is the
was
needed? Right. In
not
our understanding, how much investigation we need? Okay. Still there is a debate in country to country, even in my country also, for some social issues also arises in our society in the very recently, that what investigation should we do? The investigation should be meaningful, and to give the patients benefit. All investigations are not important. For documentation, some investigations are important. For example, if it is a bronchiectasis, clinically you got clubbing, and the symptoms are heavy productive sputums more in the morning, and in the chest examination, coarse crepitations bilaterally. So you are very clinically confident it is bronchiectasis. If you go for the imaging, every obvious advanced disease, chest X-ray can show features of bronchiectasis. But the best imaging will be CT scan of the chest, HRCT. Now, for the functional aspect of the lung disease, you need to go to differentiate it is restrictive disease or obstructive disease. I repeat the word. Lung function test differentiate restrictive disease or obstructive disease or mixed disease, but it cannot say this is bronchiectasis or not. I think Dr. Saima understood, and all of you. Dr. Simon.
Thank you, sir.
So,
Thank you.
so this pulmonary function test is not diagnostic test for the bronchiectasis. Understand? Rather, HRCT could give the idea of bronchiectatic changes in the airways. Okay. So it is not much important to say the pulmonary function, but to say the functional status, we have to say for the pulmonary many other function tests are there. Initial is that respiratory function test or pulmonary function test to see the obstructive or restrictive nature. But PESCI bronchiectasis is actually mixed pattern showing disease, bronchiectasis. They can show mixed pattern, this obstructive as well as restrictive pattern. Okay, Dr. Saima, I think it could give you some understanding a little.
Yes, sir, very much, too much.
Thank you.
Because
Thank you very
I
much.
got also about clapping. Thank you, sir.
So don't worry again for you, doctor. It might happen. Some accidents could happen. Many doctors actually not directly attached with our group also, but we are feeling sad for them. But don't lose your hope. It can happen in our life in many ways. Just try your best. Still, you have the chance, and all of you, to reach your target in the later on. So if you have nothing more, we could conclude our session. And those who are very new, for you that we have the YouTube channel to see many discussion of different categories, MRCGP, AKT, OSCE, and others also. And again, further expanded information for you. We are actually busy with more than MRCGP, and that's all. So thanking you, doctor, and inviting you to be in touch with next session. Hopefully, we already told you that pending thing will be the referral skill. We almost prepared with us referral skill, how to refer, how referral planning should be done. Again, it is a matter of difficulties. Somebody will tell in this way, somebody tell in another way. But how we can make our best referral plan, we will try our best to discuss with you in future. We might be wrong, doctor. We cannot assure you that we will be 100% right. You can opine your views. So try your thinking and keep your eyes in our group. Already we started some slides to be posted in the group about the referral. Please go through these. Maybe 2 or 3 slides are given, scenarios are given to know your decision-making plan. Immediately, few hours later, you are getting the answers. Though these are actually the question of the AKT, but you need to know it about the referral. And we will discuss in live session by the mercy of Almighty in future. So until then, very, very goodbye and stay blessed and stay in the study, doctor. Thank you very much. Keep us in your prayer as well. Thank you all. Ma'asalama, doctora. All the best. See you.
Assalamu. Thank you.
Welcome, doctor.
Thank you, Dr.